Good afternoon, everyone. My name is Dr. Tracy Newman. I am a pediatrician and the medical director at the North Dakota State University Center for Immunization Research and Education. It is my honor to introduce our esteemed experts, Danni Pinnick and Lynn Bahta, who will be presenting today's webinar, When Measles Strikes, Engaging Community Partners in Outbreak Response. We are excited to have them share their expertise on this critical and very timely topic. Our objectives today are to review the current measles landscape and its impact on communities, describe strategies to collaborate with affected communities to enhance outbreak response, and to recognize the role of trust and communication in promoting vaccination and containment efforts. Our first speaker will be Danni Pinnick. Danni is the Immunization Surveillance Coordinator for the North Dakota Department of Health and Human Services Immunization Unit. Her job includes serving as a vaccine preventable disease epidemiologist and subject matter expert, managing the perinatal hepatitis B prevention program, and assessing school and child care vaccination coverage and compliance. She has served in this role for over 3 years and has been with the NDHHS since 2020. She has worked in the public health field for 10 years. Prior to this, she worked with Prevent Child Abuse North Dakota and the North Dakota State University Department of Public Health. Danni lives in Fargo with her husband and 2 children. We are honored to have her expertise today. And after the presentation, we will introduce our second speaker, Lynn Bahta. Danni, you can begin.
Thank you. All right, now we can see them. All right, so I suppose we all know why we're here today to talk about measles. There is quite a large ongoing measles outbreak happening in Texas and New Mexico as we speak, as well as other parts around the US. So it's very important that we as healthcare staff and personnel in North Dakota have this high on our mind and are ready to respond to measles if we see it in North Dakota or in our community. So to begin with the signs and symptoms of measles, many of us might be aware of this already. Let me move, oh, sorry. I'm gonna move excuse me. I had to move the my camera off of there. The measles timeline really lends itself to the overall infectiousness of this disease. A person gets exposed to measles and then something like 1 to 2 weeks later, they will start experiencing cold-like symptoms that are very nonspecific. So at that point in illness, it would be hard to know that it's measles that we're dealing with. A couple days after that, a person might have cough-like spots in their mouth, and then maybe a day or 2 after that, this person might start to develop a measles rash and spike a very high fever. It's not really until the rash appears that it's going to be obvious that this might be measles and that person should be screened for measles. And also, most parents or people might not present to a clinic in these early days of symptoms. Unfortunately, the 4 days preceding the onset of the rash, that person was contagious for measles. And so that's why one of the many reasons why measles is such an issue as far as prevention goes. On day 10 or later of this illness, people that are unlucky might experience symptoms or complications like encephalitis, which is a swelling of the brain, ear infections, which can even lead to deafness, conjunctivitis, which could lead to blindness, pneumonia, which is a lung infection, will happen very commonly. Some people might experience diarrhea that can leave them severely dehydrated. And the ultimate morbidity of measles is not even really known until about a decade after someone experiences the disease, because 7 to 10 years after infection, people can experience a condition known as subacute sclerosing panencephalitis, which is a very, very detrimental neurodegenerative disease that absolutely incapacitates people. So this is a very, very dangerous disease that we need to be aware of the early signs and symptoms of, and also the risks that we have in our community. Like I said, it's transmitted quite easily. The reproduction number is up to about 20 people that in one index case may get sick if they're while they're contagious. The reason why it's so contagious, in addition to having this pre-symptomatic phase that's about 4 days long, is that measles virus is very tiny and it can actually hang out on water particles in the air. So when a person is in a room, if they cough, sneeze, or talk, That measles virus gets sent out into the air and it can hang out in that environment for up to 2 hours after that person has left. So not only someone who is sharing the same airspace with an infectious person while they're there exposed to measles, but anyone that enters that airspace in the 1 to 2 hours following their presence there could contract measles from that exposure. That's huge, right? If people are not immunized to measles, which we can imagine might be very common in the waiting room of a pediatric office where we'll have lots of infants who aren't eligible to be vaccinated, 9 out of 10 people that are exposed will get measles from that exposure. So it's very easy to spread, bottom line. So this is the reason why, as vaccination rates decline, measles is the one that we're kind of most scared about and comes back the most easily. Complications, we already mentioned some of them, like encephalitis, happens in about 1 in 1,000 people. People can experience pregnancy problems if they have this disease while they're pregnant, including premature birth, fetal death, low birth weight. Pneumonia, like I said, is very common, happens in 1 in 20 children. And hospitalization is really, really common for people that experience measles. 1 in 5 people who get measles will be hospitalized. So those numbers are huge. And if you can imagine, the hundreds of people that are being affected by this disease now, if this took hold in North Dakota, we would very, very quickly meet and exceed our capacity for hospitalizing these people. People that are at a special risk, again, are very young children under 5. That's why we vaccinate starting at 1 year of age. People that are over 20 years old, pregnant women, and then people who have compromised immune systems, like people with leukemia or HIV. There is unfortunately no specific antiviral treatment for measles. It's just supportive care and to help to relieve the symptoms and address complications of bacterial infections. So a person might end up on antibiotics if they have a secondary bacterial pneumonia or something of that type. Severe measles can actually, like I said, is very common to lead to hospitalization. If a person is hospitalized or under the care of a doctor in an outpatient setting, these people might be treated successfully with vitamin A. The dosing is listed here. So this is just something we want providers to be prompted to be aware of. But it's very important that this is done under the guidance of a physician or healthcare provider. This is not something that parents should be giving to their kids. They should not consider this a replacement for measles vaccine. Vitamin A does not prevent measles. Measles vaccine is the only thing that prevents measles. In the US, as of, excuse me, I wrote the date down wrong. As of today, we have identified 378 cases. Most of these are the majority of cases have happened in children, and then the biggest proportion of those have happened in very young children, like we said. Some people haven't disclosed their ages or demographics to the public health officials, so we don't necessarily know the age breakdown of everyone. But we do know when someone's hospitalized, and 17% of these cases have been hospitalized. We have even seen something that's unprecedented in the US, in basically the last 10 to 20 years. We have really not seen measles deaths happen in the US. And this year alone, we've seen 2. So an unvaccinated child in Texas died, and an unvaccinated adult in New Mexico who was never hospitalized but was later determined to have been sick from measles. Their death is attributed to measles under investigation. Like I said, the majority of the cases that are occurring in the United States happen in Texas and New Mexico. 370 cases across 17 counties in those 2 states have been identified since late January. Vast majority are not vaccinated. 42 of the patients have been hospitalized, and again, 2 deaths. So we can imagine the incredible strain that this is putting on those community health resources. Before we had a measles vaccine, measles was ubiquitous. Everybody got measles before the age of 15, basically. Before we licensed this vaccine, over 500,000 cases were identified every year. Almost 500 deaths happen in the United States every year. Probably way, way more than that were happening because, in the days before our more modernized healthcare, people had to suffer a lot more things at home and wouldn't necessarily get a definitive diagnosis of measles. And we certainly didn't have lab confirmation at that time. It would have been diagnosed by a physician. So something like 3 to 4 million people were probably infected with measles annually. Of the reported cases, 48,000 people were hospitalized for measles annually, and then 1,000 people developed chronic disability from acute encephalitis caused by measles annually. And again, that can be blindness, deafness, or mental impairment. So we luckily, those of us who are parents now, are raising our kids in the days of the measles vaccine. We are very, very lucky to have this vaccine. It is extremely effective. In fact, it's so effective, it kind of is like the gold standard, I think, by which people are disappointed in the effectiveness of some other vaccines, which is really more than we can expect of most medicine, right? But the MMR vaccine, even with one dose, is over 93% of people will seroconvert or become immune to measles after one dose. And we routinely give that at 12 months old. We give a second dose of measles vaccine. It won't be needed to cause immunity in the majority of people, but that 7 to 10% of people that didn't respond to the first dose will respond. Most of them will respond to the second dose. And so the second dose is actually to give people's immune systems another opportunity to respond. Again, we routinely give this at 12 to 15 months old, and a second dose is given at 4 to 6 years to kind of harmonize with the kindergarten vaccines, and also because 4+ is when we can give MMR vaccine. But we can, in certain circumstances, could give an MMR vaccine younger than 4 years old. It would just have to be MMR alone, not MMRV. We'll talk about it a little bit more. We can also give MMR vaccine down to 6 months old in children that are at risk for measles, but that dose would need to be repeated once they're a year old. As far as adults go, people born before 1957, so 1956 and before that, are presumed to be immune to measles and are not therefore recommended to receive measles vaccine. All adults born in 1957 to present day, or people that are adults now, whatever the year cutoff would be for that, should have at least one documented dose of MMR vaccine or laboratory evidence of immunity. If they don't have that, it's very likely that they are vaccinated or immune from prior infection, but these people may wish to get a dose of MMR vaccine to be certain of that. High-risk people for measles and adults that should be considered to kind of need 2 doses of MMR would include healthcare workers, college students, international travelers, and like I said, people down to 6 months old may get their first dose of MMR vaccine done. And then a child maybe that's going to be traveling to a hot spot who got their first dose at like 12 months old could get their second dose at 13, 14 months old, and then be immunized against measles for indefinitely. And then close contacts of immune compromised people and people living with HIV. Some people should not get MMR vaccine. This would include people with a severe anaphylactic reaction, which is very uncommon, but to neomycin or other vaccine components from MMR, or have had that anaphylactic reaction to MMR. People that are pregnant, severe immune compromised, or younger than 6 months of age. So unfortunately, we have really no way to protect people that are 0 to 5 months old. And that's why our communities really need to be thinking about being responsible and stepping up to keep these people safe. Some people are concerned about any risks that might be posed from the MMR vaccine, and I'm happy to report that this is one of the best studied things that we give in all of medicine, and the risks are very, very, very well delineated to be this list right here. So out of 10,000 people who get the MMR vaccine, 3 will experience fever-related seizures. 0 to 1 will experience a case of abnormal blood clotting, which is called ITP. Neither one of these 2 things is necessarily life-threatening. They can be treated, but they might be kind of troubling to experience in a person. And then 0.035 of these people will experience allergic reactions. If you do the math there, that means that if everybody in the Fargo-Moorhead metro area got an MMR vaccine, 1 of them would have an anaphylactic reaction. So it's, like I said, it's very uncommon. I would also add that if you have a reaction, a known thing to be associated with an MMR vaccine, if it happens to you, you get compensated by the Vaccine Injury Fund. If you or your child get measles, every 10,000 people that experience measles, like I said, 1 in 5 are hospitalized, so 2,000 people will be hospitalized. 10 of them will experience encephalitis or brain swelling. 10 to 30 of those people will die if they're children. And 1,000 of them, so it's 10% of them will experience ear infections that could cause hearing loss. 500 might experience pneumonia. has a detrimental effect on lungs. So it's a very, very dangerous disease. If you're choosing to not get the MMR vaccine, you are choosing this other column, period. Immunization coverage rates in the United States and North Dakota have kind of gone back and forth over the years as a result of different attitudes toward this vaccine. In North Dakota, about 10 years ago, we were experiencing rates similar to what we are now through really great work on the part of NDSU CIRI and our healthcare providers around the state. We got those numbers up to about 94, almost 95% statewide. And unfortunately, they have kind of dropped in after the pandemic, probably at least in part as a result of the pandemic, but also maybe some other factors. Minnesota has unfortunately kind of been on a trending decline. And in the United States, numbers overall have gone down a little bit. But it's also important to remember that while we can look at the state of North Dakota being having an immunization rate that is relatively high, obviously a case that happens in Williams County isn't necessarily going to expose a case in Cass County. So it's really important also to consider these by county and school and smaller jurisdictions. And if we look at our coverage rate in North Dakota, it's kind of scary. We have some communities and counties that have vaccination rates as low as 50 to 60%. Some that are, dangerously low. And then I would also say the populations are much bigger in these counties, so 60 to 70%. So lots and lots of children that are vulnerable to measles infection. We also have a number of counties that are doing great with these rates. And, we look for like A+ work when it comes to MMR rates. So we really need 95+% in order to be well protected against outbreaks. But we have a number of counties that are close. And I mean, through compliance and communication with their families, probably could get back to these to better trends. So what can you as a provider do now? This is going to be, reiterating what we know, but vaccinate at every opportunity. Don't forget to check someone's immunization record when they're in there for something else. We want to be vaccinating international travelers, your families the parents were born abroad and they're maybe going to take their kiddos home. You can vaccinate them down to 6 months to go, to wherever they're going and be safe. You can give them their second dose early. So make sure that we're doing timely and complete vaccination of travelers. We want our communities, our schools, our local public health, and our clinics to help us in doing reminder recalls. We do these on the state level too, but it is much more effective, I think, coming from your own clinic. Have a high suspicion for measles. We know that this is happening in the United States. So if someone has a fever, a rash, has traveled recently and is not vaccinated, I would love to be the next person you call to talk about how we should respond to that. We should be testing this person for measles with the PCR test. We'll fast track it to the lab services and get it turned around as soon as possible. But we really want to identify measles when it occurs in North Dakota as soon as we can. And also review infection control procedures. We're doing lots of updates to our website to make sure that we have resources linked and added there that healthcare providers and the public and school and daycare providers can follow. So please go ahead and check out our website, our hhs.nd.gov/measles. I want to leave you with this. So an author that I really loved as a child, Roald Dahl, he wrote Charlie and the Chocolate Factory, James and the Giant Peach, and Matilda, had a very sad story. So when he was a young father, his eldest daughter, Olivia, caught measles. She was 7 years old. And he says, as the illness took its usual course, I can remember reading to her often in bed and not feeling particularly alarmed about it. Then one morning, when she was well on the road to recovery, I was sitting on her bed showing her how to fashion little animals out of colored pipe cleaners. And when it came her turn to make one herself, I noticed that her fingers and her mind could not work together and she couldn't do anything. Are you feeling all right? I asked her. I feel all sleepy, she said. In an hour, she was unconscious. In 12 hours, she was dead. So this is an urgent plea from an author that we probably all know from many decades ago to not forget that measles is a very serious disease that took the life of his daughter. Unfortunately, in the year before, he would have been able to vaccinate her. So it's extremely tragic. We now as parents are able to vaccinate our kids, and that is what we need to be doing. Thanks.
All right, thank you, Danny. Before we introduce our next speaker, we have a quick knowledge check based on the information so far. So please take a moment to answer the following question to yourself, or you can put the answer in the chat. If one person has measles, what percent of individuals around that person who are not immune will likely also become infected? Give you just a couple of minutes. I see lots of answers coming in. Yes, many of what I'm seeing is correct. Our answer is D. It would be about 90% of individuals exposed to measles who don't have some form of immunity will likely become infected. So thank you for your participation. I'm now happy to introduce our second speaker, Lynn Bahta. Lynn is a public health nurse who recently retired after more than 25 years of work in the field of immunization. She served as the immunization clinical consultant for the Minnesota Department of Health. She has been a frequent invited speaker to various public health and immunization related events. Ms. Bahta served as a member of the National Advisory Committee on Immunization Practices, or ACIP, from the years 2019 through 2023, and continues ad hoc work for ACIP in an expert capacity. Welcome, Lynn. You may begin.
Thank you. Sorry, my dog just started barking. Perfect timing. Thank you for inviting me to share my experiences. I'm very happy. We're going to talk about community engagement. If I can get my slides up here. And so community engagement oftentimes depends on what you're seeing in terms of the case or the outbreak that's happening. Each case or outbreak is actually pretty unique, and it means that the response that someone is going to respond to, and usually it's led by your public health officials, but it takes the whole community to really contain an outbreak and to provide outreach to the community that those individuals are relating to. And so as we think about what needs to be done if we find there's a case of measles within our jurisdiction, we need to think about, all right, what's the context of that case? Is this a case that just came back from international travel? And again, what kind of exposure has occurred since that return? Has that case been only hang out in the family and finally brought to a doctor's office, or has that case been into the emergency room several times before a diagnosis was made? Has that case been in places where there may be other individuals who have been unimmunized? And so those are all things that will set the stage for how you're going to be responding. And the goal in response, and I think Danny has highlighted that well, is to minimize the impact of our public health measures to the affected community. And so we need to make sure that we're not raising alarms after one case that had been well contained versus a case where there had been 3 childcare centers exposed. So what degree of action is necessary? And how involved must the community be? Again, if it's one case, it may just be the family that you're working with, but if it's several daycare centers or a kindergarten class, you may have to be involving the community. So you're looking at few exposures versus many. The other thing that we need to think about when we are responding within a community is to understand a little bit more about that community and what their past experience with the disease in this situation, measles, is. How do they perceive it in terms of seriousness? How do they perceive it in terms of social status and stigma? What is their understanding of the public health measures that are being implemented in that outbreak? And what kind of relationship do the public health officials and clinicians have with the community? And in some instances, if it's a broad community, you're going to probably provide a much broader approach. But if it is within a more contained, close-knit community, you may need to understand that community much more and hopefully have built relationships that can allow you to act fairly quickly. Again, as you approach, your approach within this community is going to be successful or effective if you've already had a previous relationship and how you've responded in the past. If you've responded to, we got to stop cases rather than maybe we need to protect the children in this community, how the community perceives that care is going to be an important part of how things will move forward. The other piece of this is how our instructions communicated, and then how well our family needs identified. And so when we're thinking about response, and again, there are very specific public health measures that will be implemented, and I'm not focusing on that as much as I'm focusing on the relationship and how your response in that relationship can make a difference, both in the current outbreak and then maybe outbreaks to come. And probably one of the most important things is to ensure when you talk to the family about a child or an individual in their household having measles, that you're allowing enough time to really provide the information that is important for them to know and to understand. And in situations where you are working with an immigrant community or a newly arrived immigrant, it's very critical to ensure that there's a professional interpreter present. Family members really don't cut it, and mostly because medical terms are not well understood. And then the other piece of this, when you are telling a family that their child or that individual has to stay home a certain period of time, and maybe those who've not been vaccinated in the household have to stay home for 3 weeks to be observed, that could land parents to be homebound with those individuals. And so it's important to, again, reach out for immediate needs. Do you have childcare? Because or do you have to work and need childcare? Who could you get, and can we check their immunization status? What kind of food or supplies are needed? If it's a young child, do you have adequate diapers? And then what kind of work situation? Is this person in a situation where absence from work is not tolerated? All of those things, again, will impact how that family and those individuals respond to the directions that have been given by public health officials. Also, and this is somewhat of a repeat of this previous, for isolation and quarantine, I think it's important to keep in mind that measles isolation and quarantine is very different than what we got used to with COVID. And this could be a teaching point to certain communities who really hated to be quarantined because of their exposure to COVID or isolated because they're sick. We're seeing lengthier quarantine, usually up to 3 weeks from the last time a person was exposed to that measles case. We have a very highly infectious disease, and that can be, it's much more infectious, as Danni said, than most other viruses or bacteria. And so that's one of the reasons why measles is a concern in terms of outbreaks. And the other piece of this is that there is time-sensitive prophylaxis options that can be performed, and that's in terms of within a certain period of time, those who've been exposed can be vaccinated, and those who are more vulnerable and can't be vaccinated can receive immune globulin. And so those are all things to consider as isolation and quarantine and responding initially to that case occurs. And I want to remind you, and this is something that working for the Minnesota Department of Health, I saw and heard about during our measles outbreak responses, is that exclusion has caused serious hardships for families and for the community. Oftentimes, the parents or the adults are in jobs with less flexibility. We see non-compliance for the guidelines, both intentional, but even more so unintentional because of lack of understanding. And those that are intentional are often to preserve a job, to preserve the economic stability of that particular family or household. And again, possible social stigma. And within Minnesota's boundaries, we have a few communities, and probably the one most known is our large Somali diaspora in the Twin Cities, where there has been significant misinformation flooding the community, and measles MMR rates are at dangerously low levels. And so in our response to alerting the community, as we've made it public, it's actually created stigma to the community that has felt very insensitive. And so as we're thinking again about how we respond to few cases versus many cases and the degree of communication, we need to keep that in mind. In responding within a community, when you begin to develop community engagement, it really begins before an outbreak. An outbreak is not the time to build those relationships. It is doable, but oftentimes it delays the communication and the response such that more cases occur. And so if you can now proactively think about things that need to be done ahead of time, and I've just highlighted a few of them. It's important to develop a communication action plan, and that needs to include what are your guidance for the breadth of approach that you're going to have. And do you have messengers identified? Have you built any relationships? Your effectiveness in messaging needs to include your awareness of community attitudes toward vaccination and their perception of disease. Within the community, the Somali community in Minnesota, disease was perceived as very dangerous, and that became an important motivating factor when parents realized that measles was circulating in their community. They had a perception that that only happened back in Africa, where they saw many children die. And so having that understanding can provide you with unique tools for message effectiveness. And then the other really important thing is to be aware of how information flows within that community. So who are the influencers and trusted messengers? We always look to physicians and other clinicians because they really are a highly trusted member of the community when it comes to medical issues. And that's true survey after survey in the broader community and in smaller communities. The other thing we need to understand is this: what is the source of misinformation, if that is a driving factor in this particular outbreak? Is it misinformation that has caused the low vaccination rates, and what information is that? But the other piece of this is to discern whether or not these low rates are because of poor access to vaccination. Again, maybe lack of knowledge about where parents can get low or no cost vaccines. And then what venues provide the best information dissemination? So where clinician's office is a very important part of this, but also are there pharmacies within a community where there are a lot of trusted messengers as pharmacists or pharmacy techs? Where can that information be shared so that the community can broadly get that information? And so just a reminder of why we want to be partnering with an impacted community. Again, you need trusted messengers. I'm going to say that a lot today. You want effective access to the community. I remember being said, you're in charge of getting this information to the community. And I'm going, I don't know anyone. I don't know who to ask to share that information. And certainly I do now, but that again, if you can have those relationships established beforehand, again, through promoting not only immunization programs, but also other health programs that are relevant to a community. And then by partnering with an impacted community, you can develop a more effective framing of the issue. What's relevant to that community may be very different than another community. And how should you be partnering? You need to be doing it with humility and flexibility. Humility meaning you aren't the one that's going to be, quote, rescuing, unquote, the community. You are the one that's going to be the bridge for what the experts know and what the community needs to know. And you're going to use that bridge of trusted messengers to get that message to the community in an effective way that can actually create action. And then the other piece of this is flexibility, and sometimes getting that message to community members, I'm really sorry, is the flexibility, being able to maybe have an information session on a Saturday morning, or having extra immunization clinics in an evening that isn't typically a time where you would necessarily be working. So sometimes that partnership does require work beyond the typical 9 to 5 workday. Additionally, as you begin to think about this partnering, some things that you can do in the midst of an outbreak would be to identify and meet with community leaders, and they can include faith leaders, political leaders, health professionals who are from the community. And more importantly, rather than telling them what should be done, solicit ideas for how should this be done? What actions can the leaders take? And it's important as we're working with our communities, and particularly communities where there's been a disparate level of care that's been inequitable. It's important to remember that we're asking them to do some of our work, and reimbursement may be something that we should be expecting to provide. And then what messages are meaning and how should they be delivered would be the other piece of this. In my experiences meeting with community leaders, I always take the opportunity to learn from them and to find out from them, what is the latest kinds of information that's circulating in the community, and who are the parent audiences that may need this information. What happened 20 years ago when we had newer immigrants is going to maybe be different than what we're seeing now that we have second or third generation immigrant Americans. And so messages and how they're delivered may change over time. And then make sure that you're using existing community outreach resources. When an outbreak involves a vulnerable group of children, you want to think about how could you message through child care directors or school administrators? Are there housing venues that could provide community rooms to provide small information sessions? And would faith centers be appropriate? In some instances, yes, very much so. In other instances, it may be offensive to the community. So again, working with those leaders will help you understand that. And just a little bit about what happened in our response when I was working with the Minnesota Department of Health. Again, as I've mentioned before, this was an outbreak that primarily impacted a close-knit immigrant community. And so there's two things. You have low rates, but you also have a community that does a lot of things together, and socialization was a very important part of their daily life. And so trying to understand that is an important part of how quickly we need to send out those messages, and also how to send those messages out. And because of our previous experience with outbreaks, we actually had hired staff from that community, and they developed excuse me. My treats didn't work. My treats didn't work. I'm sorry. We had developed, or they had developed, a Somali Public Health Advisor Group, and that was already existing. So in 2017, when we recognized that we had an outbreak in which there were multiple exposures in several daycare centers, we quickly activated, or quickly sent out a message to this group of people, so that at least they knew immediately that we were looking at a lot of cases that could be happening very, very quickly. And then, of course, we developed and directed specific key messages that could be used by the public health advisors, and they were vetted by our internal staff so that we could get those messages out. And some of the partnerships or the individuals that were part of that partnership included health professionals from the affected community, and they would often get on the community-based radio shows or their TV shows that were sponsored by community members. We've worked with faith leaders, child care center administrators who had previously not really understood the importance of following the requirements to submit their immunization data to the state. And that's been a key action going forward from that outbreak. And again, the Somali Public Health Advisors played a key role, especially initially, and then in gathering other leaders and leadership in the community as the outbreak went forward. And the other thing for us to remember is that within the Minneapolis-St. Paul area, we have a large Somali diaspora, but we also have concentrated communities of Somali in other parts of Minnesota, and we felt that it was necessary for them to be aware, because oftentimes people are traveling back and forth, visiting friends or relatives within those communities. And so outbreaks could be a potential there as well. When we are developing message, they need to be clear and succinct. And this is something that I always share with my colleagues as we're trying to write things is less is more. And both oral and written information need to be available. And we actually probably use more oral venues than we did written materials. Sometimes it's our initial response to, oh, we've got to make a information sheet and get it translated right away. And oftentimes it's better to get someone on the radio who speaks the language and is seen as a trusted messenger to get that information out. And that the written stuff can come a little bit later. And so again, because of our previous relationships, again, when I say our, because of the Minnesota Department of Health's previous relationship, radio was used, TV was used, and there were a lot of community meetings, and they were held in schools and childcare centers, faith centers, and then any within that community, oftentimes there were what we call malls, shopping malls that had unique wares for the community that were difficult to find in the broader community. And so we knew that there were a lot of people who needed to hear that message and would be exposed to that message within those kinds of settings. And again, you're going to need to know what those settings are within the community you're working with. And as I mentioned, in terms of a succinct, clear message, this was probably the main piece of information that we sent out. And there were 3 messages. There's measles in the community. Make sure that your family is vaccinated and call your doctor or clinic if you see symptoms. And so those were kind of the 3 things that we felt were important to get some action steps going for the parents who are concerned about measles. And again, I'm just listing some of the venues that we used. And there may be some very unique ways that the community may be using. In our circumstance in 2017, the community would often do what they call teleconference calls. And these were oftentimes nationally based, sometimes coming right out of Minnesota, but often listened to globally. And so some of the health professionals were able to get on some of those calls to give information out to the community. There are going to be challenges that you are going to be aware of, and these were some that we found in the 2017 outbreak. And again, a big one was perception by some Somali Minnesotans that they were being targeted. And certainly that wasn't the intention. It was more to create awareness, but that was how it was perceived. And we really needed to find different ways of messaging so that could we could mitigate that concern. And communication about an outbreak and what should be done in an outbreak can be very challenging because of the isolation and quarantine issues. When you have people who aren't responding to that, those recommendations or guidance, sometimes legal aspects need to be pulled in. Again, you want to use the least restraining or restraining measure to work with a community, no matter what community or individual that is. The other thing was that in the contact with those whose children had been exposed, they were having a really hard time understanding what was being directed. We would say your child needs to stay away from their child care for 3 weeks. And they were thinking the problem was the child care center, when the problem was they had been exposed to measles. So they would bring their child to a different child care center, and then the child would develop measles and expose more children. And so those are some really complex things that always need to be considered. And again, another really complex thing is if someone's been referred to a clinic to be vaccinated because they were exposed and they need to be there within a certain period of time. Some of the clinicians are saying, okay, you're set to go, and they think their child can go back into whatever setting when vaccination at that point didn't mean they were free to go because they had been exposed. So those are some things to keep in mind. And in situations where the driving factor is vaccine refusal, we found that there were vocal parents who had allied with anti-vaccine groups in the community, and they would oftentimes insert themselves into some of these community meetings, which were open to the public, and give anecdotes that made it seem like there was that the vaccine was causing these problems. And the other problem was most of our outbreak messages focused on the preventing measles and did not really address why parents were not vaccinating. And it was because of their fear of autism. And again, you're going to need to understand that. And we did some more complex messaging following the outbreak to talk more and address that issue. So if you're a clinician or a vaccinator, some things to do is among the parents who might be refusing vaccination for their child, keep the conversation going, keep building that relationship. Also know where those immunization gaps exist. Danni did a great job showing you where some of the gaps are in North Dakota, and it looks like that the western part of the state may be ripe for some measles cases. And it's important to reiterate what Danni said, to think of measles as a differential when a child presents with fever and illness. And that's where you can think about, did they travel recently, or did they have a family member or a neighbor that had traveled recently outside of the country? And developing a plan to recall or contact unvaccinated children during an outbreak. Oftentimes, the risk assessment a parent uses to refuse vaccination changes in an outbreak, and you can recall them saying, hey, it's circulating in the community, come and get vaccinated. And you can use the registry tools to identify those kids. And as Danni said, assess vaccination at every visit. Some other things when an outbreak has been declared are for the clinics to be reviewing MMR vaccine inventory. And again, how many kids would you be seeing in your particular clinic or source of service? It may not be a lot, and so you may not want to beef up your inventory. But if you see a lot of families where there has been vaccine refusal, you want to bulk that up. Execute your recall plan, stay informed with state guidelines, understand the reasons for the vaccination request, that a child had been exposed and they were told that they could get their child vaccinated versus taking action because they don't want their child to get measles. How you inform them in terms of instruction will be important. You may not want to say you're good to go, but rather follow what the health department has instructed you. And then consider off-hour clinics and work with the community. And then, hang on here. Review your customer service practices with staff. And something that MDH learned post-outbreak was that parents were really nervous about getting their child vaccinated. They were nervous their child would get measles, but they also were afraid. And so reassurance, not only by the clinician, but by the staff that they were interacting with, was really important, and to be welcoming and instructive. Your child may develop a fever after an MMR. That's okay, that's normal. This is what you should do. You know, those kinds of instructions are really critical during this time. In public health, I think many of you already know these things, but again, can't iterate it enough. Don't wait to build those relationships. And in particular, partnering with communities that are experiencing health inequities to really either establish an advisory group, really understand what's important to them, and maybe even consider contracting in between cases and outbreaks, because again, keeping that relationship going it provides or builds goodwill. And then to initiate ongoing communication with community partners, and to seek their input about what's important for them in terms of health, and then adjust your action when needed. So you want to make sure that your messages are culturally appropriate, and that's probably for me the source of humility for me is I have learned so much from my work with community leaders, and they aren't shy to share when I'm off base, and I really appreciate their candor and really accept that that's that I needed to know that information. The other thing to consider, and oftentimes these are more personal, you can't assume that your altruistic intent garners trust. You need to presume that there needs to be a way to build trust for that within that community, and to use ethnic and community-specific venues. Recognize that the voice of the community can't be represented by just one person, and to ensure that the messenger that's being used is knowledgeable and respected by the community. Sometimes you may get someone who is respected, but if they don't know anything about the disease, they can be caught in some of the misinformation and actually create more misinformation. I thank you, and I don't know if we have time for any questions, but I'm here.
Thank you, Danni and Lynn, for such incredible presentations. We do have one final knowledge check based on what we just learned. So please take a moment to answer the following question to yourself, or again, you can put it in the chat. Which of the following is a key strategy for collaborating with affected communities to enhance outbreak response? I'll let you guys look at those. I think for the respect of everyone's time, I am seeing some answers coming in. Thank you all. Our answer is B, utilizing culturally tailored communication and working with trusted community figures. Lynn did a great job of explaining and reviewing that.